Hello, Mian, are you there? Mian Ghoul?
Yeah.
Oh, okay. You can hear me okay?
Hey, I'm good. But I don't know how to share my PPT.
Oh, okay. Are you a presenter?
Yeah, I'm presenter.
Oh, yeah, okay. I'm sorry. Nice to meet you. I'm Dr. Bennett.
Dr. Ben, hello.
Okay,
Nice to meet you.
let me put my camera on there.
Professor Ben, hello.
There we go.
Hey.
Yeah, I had the wrong picture for you, the first banner. I don't know if you realize that. Okay. You want to put your camera on?
I have camera in the my laptop.
Yeah, at the bottom left of the screen, there's a little picture of a camera. You got to click on it. You have Zoom, right? At the bottom left of the menu, you got to turn the video on. You got to turn that camera on.
I didn't see it.
You have Apple or you have Windows?
Windows.
Okay, the bottom left.
Bottom left.
Left of your screen, there's a picture of a microphone and a camera. A little icon. You see those icons?
Yeah.
Okay, the icon with the camera, you've got to turn that on.
Okay, let me see.
There's a menu next to it. Oh, wait a minute. Okay, I'm going to get. Okay. It looks like you're not connected to your camera.
Hey.
Yeah, you're not connected. Your system is not connected to your camera. So I think you need to reboot because I can't see I can see you have a microphone. Oh, there you go. Okay, you got
Thank you.
it. Very good. Okay,
But
you know, do you know how to screen share your
yeah,
presentation?
I know. Yeah, I know. I try to share my PPT first.
Okay,
Okay.
okay, you want to test something? I'll test something if you want to test something.
Can you see?
Perfect, perfect.
Okay, thank you. Thank you, Dr. Burn.
Okay, you have videos at all? No
I can see the
video?
video. I can see the video.
Yeah, let's test the video. Let's test.
Okay. And no video in the PPT. So
Oh, okay, no video in the presentation?
yeah, only pictures.
Okay, very good.
Thank you.
Okay,
Okay.
okay, just take it off the screen. Let me just, I'll get you off the screen. Because
Okay.
I want to show a picture of Miami Beach. Yeah.
I think it's good.
Okay, we start in 35 minutes.
Okay.
So I see you in a while, okay?
Okay. Thank you.
You're welcome. Greetings, everybody. Change my background. Just the camera. How's that, gang? Let's see, if you have any questions or comments, just you can put them in the chat. And I don't know, the attendees, can you hear me? If you can, let's see, Daniela, Peter, or Zanab are here so far. Can you just text me? Say, hey, we can hear you. Oh, thank you, Mian. Thank you for your email. Oh, good, you can hear me, Zanab. Welcome. Welcome. You know, Zanab, okay, I'm gonna let you talk. I got allowed her to talk. You can hear me, right, Zanab? Zanab, can you hear me?
Yes, sir.
Oh,
Sir, I can
good.
hear you.
Good day. Yeah, I can't let you in the panel
Mm-hmm.
because there's only the speakers are in the panel,
Okay, sir.
okay? But you can still talk.
Okay, sir. That's
Okay,
perfect.
thanks for coming, okay?
You're
And
welcome,
welcome,
sir.
welcome Daniela, and welcome,
Thank you.
welcome, let's see, who else is we got here? Peter Spangenberg. Okay. Oh, Mian, are you there? Mian Gould? Are you there, Mian?
Yeah, I'm here.
Oh, yeah. So I don't know WeChat well because I guess everybody uses that there in China, right?
Yeah.
For video, for watching neurosurgery videos, do you use WeChat?
Actually, we seldom see the video.
Oh, okay.
Yeah.
Okay.
So, but I think more and more surgeons in China know this video. So
oh, okay.
that's a process to spread. Yeah.
Oh, okay.
Mm.
Okay. And do you have a group in China in neurosurgery that speaks English that have a channel in China?
Actually, I live in the north of China, so most of people maybe speak Russian, but English not good at
Right.
English.
Oh, wow. I would like to
Sorry about that.
know. I would like to know the channels they use and where it is, because
Okay.
I can also televise that on Neurosurgical TV.
Yeah, I will let more and more people know. More and more
Yeah. And more people see it.
colleagues know.
More people see it at a central place.
Yeah.
They can go to Russia. They can go to China. Hopefully we do more China webcasts that speak English. And what I would like to do is have a conference in an area of like neurovascular, maybe tumors, and have half the speakers Chinese, 10, and have 10 English speaking, like 10 Chinese that present in English and 10 English speaking neurosurgeons from the rest of the world. What do you think of that?
Yeah, you are right. I think this is a process to let more Chinese neurosurgeons know the TV, right? But I think most of surgeon, most of neurosurgeons can speak English.
Yeah, I'm sure they can understand it, right? Maybe not speak too good, but I'm sure they can understand the basic things.
Yeah, the basic, yeah.
Yeah, I think that, yeah, it's like other languages. They kind of have an idea. But I find that some countries like their own language, like in Latin America, when I first started doing telecast in Latin America, I asked the neurosurgeon, do you want it in Spanish or English? And a lot of them said Spanish. They
really?
said that they would prefer,
so close to,
they prefer it in their native language. And other countries, some countries say no, English only. And other countries say no, yeah, maybe in Russian we'd have more people come. We've done them in Russian. We've done them.
Yeah, that's a good idea. So, because English is so popular in the world, so it's the basic English, basic to communicate language by the medical workers. I think, yeah, so should be speak English so more people can understand what you mean, what you say, right?
Well, we just need to communicate, we just basically need to communicate, establish lines of communication so we can let each other know about education.
Yeah.
So
I hope more people.
Hello, Ben.
Hello, John.
How you doing? Mian's here.
Fine. Yeah.
Yeah, I'm here. Hello, Professor Xi.
郭教授好，哎，
教授好。
你的话筒打开了，好的。
打开了，对。
Yeah, I was pumping me on for information about, you know what I would like to do, Ben? I'd like to have a conference in maybe a month, 2 months in, say, tumors or neurovascular, and have 10 speakers from the rest of the world and 10 from China. Or what do you think of that?
I don't got you. So
Oh, I mean,
what?
a conference with 10 Chinese presenters and 10 from the rest of the world. In English.
Okay.
Maybe in a month, maybe 2 months, maybe.
Okay.
I send you the idea. I'll send you.
Okay.
Okay. How many bypasses today?
Oh, now we are all locked down in home.
Oh, wow.
Yeah.
Still, huh? Still.
Yeah.
Wow. Wow, that's been a week. Week.
More than a week.
More than a week. Yeah, I'm not sure if Yuha, I told Yuha. Is he coming, Ben? Too?
I'm not sure.
Okay, I just wrote him an email. How has the traveling been? Can you travel at all? The other parts of China, you can't even leave Shanghai.
Yeah, now we can't left Shanghai. Last year it's okay.
Okay. Let's see. I'm not sure the people are trying to get in, Ben. I don't know if they're with you. Can you see the panelists there? Lu Yi, Wu Yang Yang. Is he a speaker? I think he is.
喂，什么？
Wu Yang.
Oh yeah, perfect. I can see you now.
Hello, Wu Yang.
Hello, hi, how are you?
How you doing, Dr. Bennett?
Hi, I'm Yang. I'm one of the neurosurgical residents here at Hopkins.
Yeah, thank you. Thank you. And you know how to screen share and you know how to.
I do.
Okay.
Yes, I do.
You have any videos in your presentation?
I don't have any videos.
Okay, so we don't need to go over that then.
Yeah, exactly.
Yeah.
Was it causing problems for the videos?
No.
Oh, okay.
No, usually it works, but it's good to make sure it works good. Sometimes you have to do the video outside of Zoom and then come back to Zoom. So.
Oh, gotcha.
Okay.
Hello, Dr. Yang.
Oh, hi, Dr.
Hi,
How are you?
Hi.
Nice to meet you.
Nice to meet you.
Have you talked to Wan Li, Ben?
Yeah, I will call him.
Okay. I love Chinese food. I eat it 3 or 4 times a week.
Oh, okay.
Oh man,
You love Chinese food.
Oh, yeah, I live
Uh-huh.
near a Chinese restaurant and sometimes lunch, sometimes dinner.
Where are you right now, Dr. Bennett?
Miami Beach. in
Miami
Flor-
Beach. Oh,
Florida.
good.
in Florida. You're up at Johns Hopkins?
Yeah. I went to Miami like a few times. It was great. It was very international. A lot of Hispanic food, Chinese food as well. They have good Chinese food over there.
Yeah, yeah. Well, I
yeah.
love it. I love it.
Yeah. Yeah.
So I could live on it. Chinese and Italian could live on
Yeah.
that.
Are you
So
currently
Dr. Yang,
practicing?
you born in States?
No. I was
No.
born in China. I actually did my
Okay.
medical school in China.
Ah,
Yeah.
which school?
Actually, I was mentored by Yuan Li.
Oh,
He was
okay.
he was actually my mentor. Yeah,
Okay.
one of my mentor. Yes.
Okay.
Yes.
So how many years did you stay in Johns
I
Hopkins?
I came in the States in 2010. So now it's about 12 years. Yeah. Yeah. And has been staying at Hopkins for like the past 12 years, basically. Yeah.
How do you like Baltimore?
Well, it's not as bad as what people are saying.
Well,
It was
they have crabs, right? Crabs there, right?
crabs, yes, the Maryland blue crabs. Although most of the times the blue crabs were imported, like not in non-crab seasons, they were imported from Texas, I heard.
Oh, really? Up to
From the
wow,
Bay
up to
Area, from the Caribbean Bay, yeah.
Right,
and
right.
then in crab season, it came from the Chesapeake Bay.
Chesapeake Bay.
Yeah.
And then, so the season is in the summer there?
The season is summer and autumn.
Autumn,
In
okay.
the fall, yeah.
It's the
John,
same as,
when would you move to Hawaii? You mentioned you will move to Hawaii. John.
Me? Oh,
John.
maybe.
Yeah, maybe. Okay.
Maybe, just for a while. My brother lives in Maui.
Okay.
And it's only 8 hours from China.
Yeah.
That's not far. And a lot of Chinese go there for vacation. Japanese, Chinese. Have you been there? Ben?
Yeah. Twice.
You went to a conference?
Yeah.
In Hawaii?
Yeah.
In Maui or?
The main island, the biggest one.
Oh, the big Hawaii.
Yeah, Hawaii.
Hello, Wan Lee.
Hi,
Wendy.
John.
Welcome.
Hi. Dr. Shi and Wu Yang. Long time no see.
long time no see.
Right, yeah. So everything okay, right?
Yeah, we started 3 minutes. We got the speakers here all set. They both know.
Dr. Guo from Harbin, he's also here, right? Dr. Guo Mian. Hi.
Hey.
Yeah, I'm going to make you administrator, Wan Lee, see here, which you can let people into the panel. You remember that?
Yeah, but I don't know how to do it. Anyway, yeah, you can maybe.
Oh, I'll just briefly tell you. On the right-hand side, you see the panel?
Yes.
Okay, that means that you have the power to let people in. So next to their name, there's a more, and then you open that, it says.
Okay, I saw.
It says admit to panel.
Okay.
So if there's someone there that needs,
I saw
someone there that needs to come in, you let them in.
Great. Okay.
Yeah. So there's some names I don't recognize. They're written in Chinese script, so.
Yeah, me too, but I don't know. But yeah, everyone is welcome. I don't know. So.
Okay, we start 1 minute.
Yes.
I'm going to mute everyone that's not speaking now, except for Wan Lee.
This webinar will be broadcast in China, right? Dr. Xu, right?
Yes.
Right?
Yeah.
Yeah, that's Dr. Bin's territory, thank goodness. But it'll be on YouTube, it'll be on Facebook, It'll be on the website, Neurosurgical TV. And lots of WhatsApp groups. I don't know. Do you guys use WhatsApp in China? I don't know.
No.
No? Okay.
Yeah.
Yeah,
No,
we need
no.
VPN to use it, but I think it's not so popular.
Oh,
Yeah,
okay.
maybe like WeChat.
Yeah, I've got to learn WeChat again.
Yeah.
Okay, you ready? Okay, you ready, Wanli? 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. Today we have the pleasure of broadcasting the second broadcast of the Chinese Neurosurgical Journal. This is webinar number 2. First of all, I'd like to thank Bin Zhu and Yuha for setting all this up. And I'm going to turn it over now to Wan Li Zhao, a director of cerebral vascular surgery at Beijing Tiatan Hospital in Beijing. Welcome, Wan Li. It's all yours.
Okay. Good morning, everyone in United States. And good night, everyone in China. Also, all around the world. If you're hearing, this is the second webinar of the Chinese Neurosurgical Journal, a special journal from Neurosurgical TV, and we just start to cooperate with Dr. John Bernard and his Neurosurgical TV to organize this webinar and every 2 weeks, and for every webinar we will invite 2 or 3 speakers all around the world and to introduce their clinical study or basic research experience. And we wish to have more submission to our Chinese Neurosurgical Journal. So yeah, and this special webinar will be moderated by Dr. Xu Bing from Shanghai Huashan Hospital and myself. And tonight we have 2 speakers, one from Johns Hopkins Hospital, Baltimore, United States, and the other from Harbin, China. It's the second affiliated hospital of Harbin Medical University, Dr. Guo. And yeah, I think we can just start, and everyone are welcome to have some free discussion after these 2 talks. So maybe Dr. Xu, you can introduce the first speaker.
So the first speaker is Professor Guo Mian from second affiliated hospital of Harbin Medical University. So his topic is about the glioma stem cells. Dr. Guo Mian, so please.
Okay, I share my PPT. Okay, hello everybody. Thank you, Professor Xu, for that kind introduction. I appreciate the opportunity to present my research work on wind-containing signaling pathway and glioblastoma stem cells. Hopefully, more and more excellent articles are published in Chinese Neurosurgical Journal. Our surgeons around the world can benefit from it. Okay, firstly, we all know that glioblastoma is most common, aggressive, invasive, heterogeneous, malignant primary brain tumors in adults, and less common in children. Glioblastoma accounted for the majority of glioma. Median survival of glioblastoma is only 14.4 months. The 5-year survival for glioblastoma is only 6.8%. The incidence of glioblastoma is 3.23 per 100,000 population and still increasing. The standard therapy, including surgical resection, radio and chemotherapy, severe malignance, and extensive heterogeneity affect the standard treatments and overall prognosis. Given the poor survival with current treatment for glioblastoma, new therapeutic strategies are urgently needed. Following the finding of genetic and epigenetic profiling and the immunocells in brain microenvironment, immunotherapy, including CAR-T and oncolytic viral therapy, vaccine therapy, and tumor treating fields is still being tested. So far, didn't get more satisfactory result. So treatment of glioblastoma is a great challenge. Okay. This review summarizes the immunosuppressive microenvironment in glioblastoma. Hypoxia and the immuno checkpoint play important roles in the failure of immunosurveillance. The glioblastoma microenvironment is hypoxic because of abnormal blood vessel morphology and impairing blood-brain barrier. Upregulation of hypoxia-related factors such as HIF-1 alpha cooperate with specific immunocells from leaky blood-brain barrier to suppress the function of T cells. High expression of PD-1 on T cell surface and the PD-L1 on tumor cells lead to the energy and apoptosis of T cells. The functions of NK cells in glioblastoma microenvironment are limited. Glioblastoma stem cells have a high potential of cell renewal can development. Glioblastoma of varying heterogeneity. Glioblastoma stem cells show greater tolerance to therapies and promote tumor recurrence. Glioblastoma stem cells are located in hypoxic niche of tumor microenvironment. Besides glioma stem cells, many different cells such as microglial cells, macrophage, vascular cells, fibroblasts, and immune cells such as dendritic cells, leukocytes, and NK cells take part in the tumor microenvironment. The hypoxic niche contributes to glioblastoma growth and resistance. HIF contributes to the upregulation of VEGF and the IL-8 and supports the stem cell presence. Crucial pathways such as Wnt are also upregulated in glioblastoma stem cells in the hypoxic microenvironment and associated with the methylated FGMT type and chemoradiotherapeutic resistance. As we all know, Notch, Hydrog, and the Wnt signaling pathways are considered as stem cell signaling pathways. For a long time, we have interested in the role of Wnt signaling pathway in the development of brain and skeleton, as well as glioma tumor genesis. Since Wnt signaling pathway is highly evolutionarily conserved in animals and identified for its role from embryonic development and carcinogenesis in various tissues and organs. So we focus on this pathway. Wnt signaling pathways include the canonical and non-canonical Wnt signaling pathways. All Wnt signaling pathways are activated by the binding of a Wnt protein ligand to a frazole family receptor. The canonical Wnt signaling pathway or Wnt beta-catenin pathway is the Wnt pathway that causes accumulation of beta-catenin in the cytoplasm and is eventually translocation into the nucleus to act as an activator of transcription factors that belong to TCF LER family. Without Wnt, beta-catenin would not accumulate in the cytoplasm, since the destruction complex would normally degrade it. The destruction complex includes the following protein. Here, axin, APC, GSK3. It degrades beta-catenin by targeting it for ubiquitination. However, as soon as Wnt binds the receptor, the destruction complex function becomes disrupted. The non-canonical planar cell pleural pathway regulates the cytoskeleton that is responsible for the shape of the shell. The non-canonical Wnt calcium pathway regulates calcium inside the cell. The main feature of Wnt signal pathway-driven cancer is the nuclear location of beta-catenin in canonical Wnt signal pathway. So, this review showed the features of diffuse glioma. IDH wild-type glioblastoma usually present short clinical history. They are characterized by upregulation of Wnt beta-catenin signal pathway, while mutation of IDH result in decreased activity of Wnt beta-catenin signal pathway. That in turn decreased proliferation and migration of glioblastoma. In the last slide, we saw the canonical Wnt and the Wnt beta-catenin signal pathway are the same. IDH1 mutation reduced the malignant progression of glioblastoma by causing a less aggressive phenotype of glioblastoma stem cells. Opposed Wnt beta-catenin signal pathway activity is observed between IDH wild-type and IDH mutation glioblastoma. And this could be included in glioblastoma classification. This could be one of the reasons of more malignant behavior in IDH wild-type glioblastoma. So, Wnt signal pathway plays an important role in many human cancers. Although new mutations in the major components of pathway or alternations in the pathway, it has been reported that the continuous activation of beta-catenin in tumors. These findings confirm that there are other factors contribute to activation of beta-catenin and its downstream pathways. Here, we list the crosstalk among Wnt and some cancer cell progresses, including no-coding RNAs, oncogenetic signaling, autophagy, drug resistance, apoptosis, stem cell maintenance, epigenetic regulation, and glucose metabolism. So Wnt beta-catenin signal pathway is so important for glioblastoma malignancy. This review shows the potential benefits of inhibiting Wnt beta-catenin signal pathway in glioblastoma. Wnt inhibition could decrease stemness of stem cell, prevent tumor invasion, and decrease therapeutic resistance. Wnt inhibition impacts glioblastoma vasculature by blocking angiogenesis. Signal inhibition results in increased blood-brain barrier permeability, allowing for improved drug delivery. Okay. This is my previous work. I studied the protein cyclophilin A in my postdoctoral period and still focus on this protein now. Cyclophilin A was first found by binding with immunosuppressant drug cyclosporin A. Cyclophilin A is a PPIase, which assists protein folding and trafficking, and was found to be overexpressed in various types of cancer. This review summarizes the functions of cyclin A. Cyclin A has important roles in many biology conditions, including protein folding, trafficking, and T-cell activation. Current research suggests that cyclin A involves in cardiovascular disease, neurodegeneration, aging, viral infections, inflammations, and cancer development. Okay. We first compared the brain and skeletal phenotypes in cyclin A wild type and knockout mice by micro-CT and immunohistochemistry. Cyclin knockout mice demonstrate lower bone mineral density, reduced osteoblasts, and increased osteoclast numbers. Expression levels of chondrogenetic differentiation occurs, and transcription regulators was all significantly lower in cyclin knockout chondrogenic cells. This indicates that cyclin plays a functional in brain and skeleton development. Cyclin is present in highest in concentration in the brain. We then analyze the expression of cyclin in brain tumor. Firstly, we found that the expression of cyclin is increased in various cancers. We then examine cyclin expression in glioma through analysis of GEO, CCGE, and TCGA databases and clinical samples. Cyclin expression was higher in multiple types of glioma and upregulated with tumor progression. Patients with cyclin O expression have shorter survival time based on CCGA and TC databases. This work below shows the glioblastoma stem cells isolation from the clinical samples and the preparation for next experiments. Still in GEO database, we compare the neurospheres and the primary tumor. Cyclin is upregulated in neurospheres, which contains more glioblastoma stem cells. After induced differentiation, the cyclin levels downregulated. We knock out cyclin and found stem cell markers like nestin CD133, SARS2, and NANOG decreased by a series of assays. The data suggests that high levels of cyclin in glioblastoma, especially glioblastoma stem cells. Cyclin requires for maintenance of glioblastoma stem cells. To assess the role of cyclin in cell renewal of glioblastoma stem cells, we use the limiting dilution method, neurosphere assays, and the BRDO assays in cyclin knockout glioma stem cells. The data confirm that cyclin plays an important role in glioblastoma stem cell self-renewal. Because cyclin is important for glioblastoma stem cell maintenance, we next investigate whether cyclin is involved in radioresistance in glioblastoma stem cells by wet blood. We expose glioblastoma stem cells to increasing dose of irradiation and increasing time. Cyclin was promoted by irradiation. Survival fraction and the flow cytometry analysis further demonstrated that cyclin knockout reduced the ability of radioresistance. The patients with glioma was divided in high and low cyclin expression groups in TCGA. We did the gene expression and pathway analysis. Cyclin takes part in process of Wnt. Ingenuity pathway analysis further confirmed that high correlation between Wnt signaling pathway and cyclin A. Okay, we next perform RT-PCR Western blot to surface assays to check with Wnt beta-catenin signal pathway in cyclin knockout cells. As we expected, the Wnt beta-catenin signal pathway targeting GE and activities were reduced in cyclin knockout cells. Since beta-catenin is the key mediator of Wnt beta-catenin signaling pathway, we thought maybe Sanfei functions through beta-catenin. So next, in clinical samples, we found that the level of Sanfei and the beta-catenin were both elevated in all grades of glioma. Pearson correlation analysis showed positive correlation between Sanfei and the beta-catenin. Immunohistochemical staining revealed that nuclear location of Sanfei and the beta-catenin were closely correlated. Okay, we next investigate the mechanism. Since beta-catenin functions by nuclear translocation, we test whether Sanfei help beta-catenin translocated to the nuclear. We performed baseball immunofluorescence analysis in beta-catenin or Sanfei knockout glioblastoma stem cells, and found beta-catenin accumulation in the nucleus didn't require Sanfei. However, Sanfei is only able to translocate it into nucleus in the presence of beta-catenin. Next, we performed ProDAM and co-IPIC and found Sanfei, beta-catenin, and TCM4 binding together. ChIP-ICs confirmed that the Sanfei could regulate the interaction between beta-catenin and TCM4. Finally, the experiment in vivo further confirmed that the important role of Sanfei in Wnt beta-catenin signal pathway. We now collaborate with Professor Tian from Harbin Institute of Technology in clinical translational research by targeting Sanfei and the beta-catenin pathway. We use stereotactic technology to inject biomaterials containing nanopattern embodies like Sanfei antibodies into the tumor cells in order to target the protein of interest. We also work with Professor Tian to culture glioma stem cells in 3D biomaterials to simulate the tumor microenvironment and develop biosensing system to monitor cell self-renewal and the proliferation in 3D system. In summary, Wnt beta-catenin signaling plays an important role in glioblastoma stem cell maintenance. This process requires Sanfei precipitation, Sanfei binding with beta-catenin and how beta-catenin interact with transcriptional factor TCF4 to activate the pathway. We now collaborate with Professor Tian of Harbin Institute of Technology and Professor Robert Chu and Shen Hu of UCLA. I appreciate their helping us. That's all. Thank you.
Thank you, Dr. Guo. I think maybe we can have the second speaker finish the talk, and then we do some free discussion together with those two speech, right? Okay.
That's fine.
Okay. So let me introduce the second speaker, Dr. Wu Yang. He is now the PGY 5 or 6, 5. Okay. The neurosurgical resident from Johns Hopkins Hospital. So today he will give us a talk focused on the AVM, arteriovenous malformation treatment. Actually, Dr. Yang, I remember he wrote the first article published on the first issue of our Chinese Neurosurgical journal in 2015, and now that article had the most citation numbers from our journal. Okay, please, Dr. Yang.
Thank you. I'll try to share my screen right now. Let me see. I might have to rejoin, Dr. Bennett. Is that okay?
You might have to what?
I might have to quit and rejoin because my Zoom is a new setup. So I need to set up I need to click on something, quit,
Okay, yeah,
and
yeah,
then
sure,
rejoin.
sure.
Okay.
So we'll take a digital coffee break.
Thank you.
You're welcome.
Okay. So maybe we can have some discussion about the Dr. Gore's topic.
Sure.
Is he still there? Yeah. So, Dr. Gore, I
Professor
think,
Guomian, can you
Yeah.
reshare your PowerPoint? The last slides you said you
Okay,
have
so
the plan.
maybe we can just let Dr. Yang do his talk and then we discuss later.
Yeah, he's
Okay.
coming back, right? Yeah.
Okay.
Very quick.
Okay, perfect. Can you hear me?
Yes.
Okay, perfect. Let me see.
I think you just quit the share screen.
Yes. So
We still don't see it yet. We don't see it yet.
okay, hold on. Let me see.
Okay, we're getting
right.
there. We're getting there. Not yet.
Can you hear?
Okay, yes.
Can you
it's
hear me and
perfect.
see me?
Perfect.
Okay, perfect. So hi everyone. I'm Wu Yang. I'm one of the PGY5s at Hopkins. And my talk today will be focusing on one of the risk factors for AVM rupture with a little bit of general background of AVMs. I have no disclosures. So AVMs, as many people here know, that is a tangled web of abnormally formed arteries and veins. It's direct connections between arteries and veins and with no capillaries in between. To describe an AVM structure, you must have three components. So it must have a nidus. It needs to have feeding arteries or feeding artery or arteries. It needs to have draining vein or draining veins. So some of those are not the case. In very exceptional cases when AVM ruptures, you will see the draining vein actually going away. And on angiograms, you will see that the AVM only has a nidus and feeding arteries without draining veins. And that's common because that's that's probably the prothrombosis of the draining vein that caused the rupture. So it doesn't mean that it's not AVM. It just means that the veins has priorities thrombosed. So AVMs as an appearance, this is an abstract picture of the AVM. It looks horrendous. And if you look at that on the Wikipedia, the pathological slides, that the whole lesion is just basically abnormally formed vessels. And it, in some cases it is when you open up the brain, it just looks like a tangled, a bag of worms, basically. So the most definitive way of diagnosing AVM is angiogram. On MRIs and CTAs, CTAs are probably better than MRIs, but they still have probably close to 2 to 5% of false positive and false negative rate. So angiogram is the more definitive way, and it doesn't mean that it's 100% false positive or negative. It's probably close. It's around 99%. A lot of the patients have initially negative angios for AVMs, and then they show up later. In a week after, especially for ruptured AVMs, that when the hematoma is compressing on the AVMs, they typically do not appear on the first angio scan. So the practice here is normally get the first angio. If it's negative, then get a second angio in a week. And a direct visualization of the lesion. This one is a more benign looking one. It basically has a small nidus. You can see the arterialized draining veins over here. It can be mistaken by arteries, but if you start get the tactile feeling of the arteries or the veins, you can get a differentiation between them. And a more ominous looking one for this one was from one of the journals published by Dr. Freelander in Pittsburgh that shows this gigantic lesion, big overdraping draining vein, and all this, what we call serpentibulus, or what I thought was initially was a bag of worms. You literally open up the dura and open up a can of worms. And we don't see this much often now because most of these gigantic lesions are referred for radiosurgery now. So we don't really open up those as much now. So, AVMs, there are a couple of ways to describe the lesion. I typically think of it as two major features. The AVM has both a feature of a brain tumor and also a vascular lesion. So it has a mass effect. There's a description of size, whether or not, based on specimen grading, it's either less than 3 to 6, or 6. You can describe the shape, whether typically it's a coned shape, like a larger cone on the superficial surface and narrowing down to the deep side, and that's a typical experience of the appearance of the AVM. But it can also appear as a round one, especially in the deep, like when the AVM is very deep. And location of the nidus can describe compactness and diffuseness, but there's a lot of ambiguity whether how to describe the AVM diffuseness. And AVM does not necessarily has one big single thing, a nidus. It can have multiple niduses compartmentalized into like one big thing compartmentalized into different niduses. And you can have multiple AVMs, especially in HHT patients. And AVMs as a vascular lesion, it does have feeding artery, has draining vein. You can describe it as deep or superficial. That's aneurysms. Some papers describe it as type 1, 2, 3, where reality is more like a prenidal, intranidal, or unrelated. And you can describe it as high flow or low flow. And here's an example of diffuse versus a compact nidus. It's very hard to tell. This is a very extreme, extreme example of how diffuse or how compact a nidus is. But in the real world, it's very hard to draw the line which one is diffuse and which one is compact. And there you have a prenidal and some intranidal aneurysms. So you can see here is a prenidal one, and here it's there. If you look on the arterial phase, there are multiple intranidal little aneurysms over here. So when talking about AVMs, obviously the mass effect lesion is part of it, but most part is vascular characteristics, meaning that what are you, what is the risk of leaving it alone? And to describe that, you have to know the natural history of the AVMs. And when describing natural history, there are a couple of risk factors. And when you consult the patient, normally the quoted risk is about 2 to 3. I'm sorry, is someone on the? Oh, perfect. Thank you.
Sorry,
So
I'll get that.
No problem. So the quoted risk is about 2 to 3%, but in reality, it can vary a lot from under 1% to, I will show you some papers that shows that it can be as much as 20% to 30% per year. So you really cannot just tell the patient, oh, it's 2 to 3% per year, and let it be. So, for AVMs, intracranial hemorrhage is the most common presentation. They suffer lifelong risk of hemorrhage, so you really do have to follow those patients lifelong, and if they're not obliterated. And the hemorrhage risk was quoted to be 2 to 4%, now being revised to 2 to 3%. It's not a big change. What's a really big thing is that what are the risk factors leading to the hemorrhage, and how big of a change can it be with or without those risk factors? So social risk factors can significantly modify this risk, and I will show you some of the papers. So this is one of the landmark papers of natural history of AVMs by Dr. Brown from Mayo Group. And they have 168 patients followed. 166 have complete follow-up information with mean follow-up of 8.2 years. The follow-up was from diagnosis to intervention or death or loss of follow-up. This is a little bit controversial now because AVMs was initially regarded as a congenital lesion. Probably not anymore because there are definitely reports of de novo AVMs. There are definitely reports of AVMs spontaneously obliterating. There are reports of pediatric AVMs that are born with it. So it's very hard to say that whether or not these are actual, all of them are congenital lesions. And the annual risk quota here is 2.2%. And if you rupture, if it's 30% mortality, and the morbidity and survival is 23%. So the size of the AVM hypertension are of no value in predicting rupture, which is very, which is actually contradictory to what we perceive, but this is what the paper shows. And this is one of another landmark paper by Da Costa. So their entire cohort, the annual risk is 4.1%, but I want to show you something over here. So this paper starts to dig into a little bit more of a how risk can be modified with different factors. So if a patient has a hemorrhagic presentation, you will see that the risk doubled to a 10% per year. And that means the patient survives for 5 years or 10 years, their risk of hemorrhage will probably be close to 100% if they have an initial hemorrhagic presentation. And if they have a seizure, their annual risk dropped down to 3.5%. And why is that? Because when they present with a seizure, they go to see the doctors early. So they don't wait for a rupture presentation to occur before seeing the doctor. So the AVM at that point was probably hemodynamically stable at that point. So they were followed for longer, they were treated, or they were observed. So their annual risk is slightly lower. And if you have associated aneurysms, you can increase that rate by 3%. Now, it may not seem a lot by increasing 3%, but it's a 3% per year rate. So if a lifelong risk, if you have a patient of expected life expectancy of 20 years, you're increasing that by 40% of overall lifelong cumulative risk. So that's a big deal. And as I said, brain AVMs presenting with hemorrhage with deep venous drainage or associated aneurysms have a twofold greater likelihood of future hemorrhage. And that was demonstrated in this paper. And the Finnish study. So this is a very famous study that Dr. her name is Niemi was a prominent surgeon at Finland. I believe he's now in China practicing. But this is a big cohort. They have a very long follow-up, 15 years, close to 15 years. They have a very limited population, single race, almost no population influx or efflux. It's an unselected population. All of the Finland AVM patients go to their single center to get treated. So it's a very comprehensive, no selection bias study. So the patients were followed from admission to death. And that's, in my opinion, a better way of following, as opposed to following them from birth to death, because you can't really assume that the AVM is congenital. And what they found is that their annual risk is 2.4%, not too much of a difference from other papers. And they found that a previous rupture, large size, and deep location with higher risk of hemorrhage. So the size over here is really contradictory to what the previous studies found, that large size actually contributes to more likelihood of hemorrhage. And the Columbia group found that in 622 consecutive patients, their risk of hemorrhage, the risk factors of hemorrhage are age, incidental hemorrhage, meaning that the patients presented with hemorrhage, deep location, deep venous drainage only, and size doesn't really matter. And this is a slide I'm talking about. So basically, when the patient has no hemorrhage, okay, no hemorrhage, but it's not a hemorrhagic presentation, they present with seizure or something else, any risk can be as low as 0.9% per year. So does it really make sense for us to treat a 60-year-old or 70-year-old if their risk is 0.9% and you do a craniotomy on those patients? It's in a gray zone, it's hard to justify. But if you have a patient with hemorrhagic presentation and all the risk factors combined, deep location, deep venous drainage, your rupture risk, notice an annual rupture risk is 34.3%. So give the patient 2 years or 3 years, they will rupture. So in that case, even if the patient is 60 years old, 70 years old, even if they cannot tolerate craniotomy, you would try to seek some other solutions, maybe radiosurgery, embolization plus radiosurgery, but you will have to treat those lesions. So this risk factors, they give a lot of weight. The treatment decision gives a lot of weight on these risk factors alone. So these risk factors are very important. And these are the more conventional risk factors for hemorrhage. Prior hemorrhages, deep location, deep venous drainage, and associated aneurysms are more established. And I'm going to focus on my talk on pregnancy. So this is a more controversial risk factor, but nonetheless has been established before by previous papers. So, and I'm going to present this case because this patient is actually still in the hospital right now. We're still managing her, and we're planning for doing surgeries next week by Dr. Wang. So basically, we have a 24-year-old African-American female who was pregnant 8 weeks and expecting to electively abort because it was an unexpected pregnancy. And she notified the family in the evening that she had a severe headache, and she was on the phone with grandparents who heard her pass out. And she was lucky because she had a very big IVH. And when EMS arrived and found her down on the bathroom floor, she's basically GCS3, pupils blown, and she's, cardiac arrest and all that. So she was transferred to JHH, and she was GCS3 TR arrival. And then the EVD went in immediately. And after EVD went in, the pupils became reactive. And here are her images. You can see that it was a pretty horrendous IVH with complete casting of all the ventricles. And the culprit lesion is this little guy that is parasagittal, single arterial feeder, drains into a deep drainage straight sinus, and the size is just 1.7 centimeters. It's a small AVM. There's no hematoma. There is no hematoma, meaning that there's no mass effect on the AVM. So this is probably the actual size of the AVM. And it's non-eloquent. It's pericallosal, a little bit superior to the corpus callosum, but it's a little bit higher. So the management decisions, the factors considered. She's only 24, so she has many, many, many years to go. She's life expectancy over here is about 75 to 80 years. So she has probably a good 56 years to go. Small AVM is non-eloquent. It's got a single drainage vein. It's got a single feeder. That means the overall structure, complexity of the AVM is not that great. It's not that complex, meaning that it's better, it's good for treatment. And the patient already elected to abort. So that's a good sign that the patient had expressed her wishes that she wants to abort her pregnancy, and that gives us a lot of leeway in decision making. And mortality is high if you release. Basically, if she was not on the phone with her grandmother, and EMS did not arrive in time, she would have brain herniated and died. And we're planning for surgery for her next week. And the fact that she's first trimester, and most of the papers describing pregnancy AVM hemorrhages are in the second or third trimester, but that's not always the case. And the fact that, and there's an anecdotal story. So basically, when I was outside her room and one of our other attendings came by, and I was debriefing him on this patient, I told him that this is a pregnant patient, hemorrhage, and came back, came to the NCCU, and he immediately turned green because he thought it was one of another patient that had a brain AVM and had a rupture. So this is how prevalent this problem is, despite what despite some papers were saying that this is not an increased risk, but this is, in reality, you see a lot of this in NCCU. And, in general, pregnancy, hemorrhagic stroke account for 5 to 12% maternal mortality during pregnancy, and AVMs attribute to, close to 40% of all spontaneous intracranial hemorrhages. And it was previously reported to be increased. A recent meta-analysis said it was not, but I'm just going to go through the papers and try to do some analysis over here. So one of the papers here, by the Brigham group, is that they examined only 54 patients. There were 5 hemorrhages, 4 patients over 62 pregnancies. Their hazard ratio was 7.9%. That's a big hazard ratio, meaning that if you're pregnant, you're more likely to bleed than non-pregnant is in a 7-fold ways or 8-fold. And their analysis was limited by a very small sample size, of course. So this is one positive finding. And there's another landmark study in here by Xingju, who is my previous colleague in Tiantan. And they examined 979 female patients as a very large cohort. And the rate in pregnancy is actually lower than non-pregnant patients. So what what my interpretation of this is that first, it's a single racial population, and whether or not it generalizes to North American population is questionable, because the pattern of how people were treated and the way that the lesions, whether or not they were treated immediately versus they will wait, and how the patients were followed are vastly different. So there was a lack of follow-up, but mostly because that these lesions were secured very immediately after they hemorrhage. So that's a practice difference between Tiantan and here. So I'm just going to dig in that a little bit more. And we had a paper before that showed there was increased hemorrhage in pregnancy that's about 5-fold, which is in generally in coherence with the Brigham paper. And our reproductive age patients were from 15 to 50, which is defined by U.S. Bureau of Census. And then this systematic review and meta-analysis. So they basically included 7 eligible studies, and 3 were included for analysis. And what they evaluated was the risk of first hemorrhage of brain AVMs during pregnancy. So regardless of how many pregnancies you have, how many hemorrhages you have during the pregnancy, they only evaluate the risk for first hemorrhage. And they found that there's no conclusive evidence of increased risk of first hemorrhage in their paper. But then there was some ambiguity in language in that paper that actually generalized to the risk of hemorrhage overall. So that's one of my critics over here for this paper. So there are several points of this paper makes it interesting or controversial. So first of all, as I said, they only value on the first hemorrhage risk, ICH risk. So the reason for not including subsequent hemorrhages are that the authors assume that once hemorrhaged, the AVMs will most likely be secured. So it's unreasonable to calculate further ICHs during the pregnancy or during in other pregnancies. And that's not the case, because there are papers showing that the rebleeding risk is low within an immediate period. So the general practice over here is that the AVM will wait for the AVMs to cool down, for the hemorrhage to cool down, and then bring the patient back later to perform treatment, either resection or radiosurgery, because we don't want to deal with angry brain. And the fact that AVM, how likely is the AVM is going to rebleed within 1 month or 2 months of time is very unlikely. So that's how we deal with it. And the only studies that they include with patients where we established brain AVM diagnosis, and that already make them low risk for hemorrhage. And the authors criticize the inclusion of childhood patients into analysis, whereas in reality, our youngest patient in our cohort is actually 13 years when they were pregnant. And because we only include patients of 15 to 50, we have to we have to exclude a couple of patients. And in that cohort, in the included cohort, the youngest patient is 16 years old. So you really cannot just say this is a problem of adulthood. And the conclusion of risk of first hemorrhage is equivocal, is ambiguous. So what is the first hemorrhage? Meaning that the patient hemorrhaged and then they just stop counting. So that's not the case, because the real decision making is that the real reality is that the patient hemorrhaged and then they were discussed with the ABM. And then what do you do? So are there going to be subsequent hemorrhages? If they're not, then you wait for a little bit and see how you treat them. If there are subsequent hemorrhages and the risk is increased in subsequent hemorrhages, not the first one, then you probably will treat it. And that's what we believe over here, that for this lady, the 24-year-old, that we think there's a high chance that she will subsequently hemorrhage, and that's why we take it out emergently. But their paper has a lot of good recommendations for future research. So I agree that we should use the WHO definition of childbearing age from 15 to 49 years old, which is interesting because they said papers who included pediatric patients should not be included, but then their recommendation is to include 15 years old patients. And the duration, and I fully agree with that it should be pregnancy and puerperium. And describe the method of how all pregnancy for each woman is captured, document how long each patient spent in the exposure period, report the numbers of previous pregnancies and subsequent pregnancies, and stratify the patient by prior history of ICH, and record the numbers of ICH both in and out of the exposure period. And that's all very important. And I think most of the papers included there did all of these things. So, in summary, what we know so far. So most of this hemorrhages happen in the second and third trimester. That's almost a known fact. Very few happen in the first trimester. There has to be something that changed during the second or third trimester in the physiological, mechanisms that prompted hemorrhages. And the risk of increased hemorrhage may remain uncertain during pregnancy, but if the brain areas are combined with high-risk features, like intranidal aneurysms, deep venous drainages, deep locations, premature termination of pregnancy should be and can be considered. And that's what we have been doing. That if the fetus is viable, even if at 28 weeks or 30 weeks, we terminate the pregnancy and pursue with treatment. And from reported data, there's either no increase in hemorrhage or 5 to 7 times increase, and mostly in the North American cohort, that is a 5 to 7 times increase in hemorrhage risk. And we know that what we don't know. We know what we don't know is that the mechanisms of possibly increased hemorrhage risk during pregnancy for brain MEMS is unknown. And my conclusion and recommendation is that the risk of hemorrhage during pregnancy might be increased. And although recent meta-analysis suggests a certain degree of uncertainty, but again, it's a risk of first hemorrhage, not all hemorrhages. And I think a more consistent study methodology needs to be developed to investigate this problem. So the fact that you're examining pregnancy patients toes on your ABM, which is already a rare disease, you don't have a lot of ABM patients, and you have to select all the pregnant patients. And on top of that, you have to select all the female patients that are of childbearing age. So that limits on any single institution that can perform this analysis. So I think it needs to be a multi-institutional, and it needs to have a large cohort. And if combined with other high-risk features, intranidal aneurysms, prenatal aneurysms, deep draining veins, pregnancy should be considered for premature termination if the fetus is viable. And here is my slide for a thank you. So I graduated from Tiantan 10 years ago. My mentors, Dr. Jizong Zhao, Dr. Shuo Wan, Dr. Yuan Li Zhao, who's here, were my mentors clinically and research-wise. And at Hopkins, I gave tremendous thanks to Dr. Huang, Dr. Tamargo, Dr. Kaplan, Dr. Bram. And here are my fellows and students, some of them are already residents over here. So Alice and Tito and Andrew are all residents over here now. So many thanks. And here are my references. Thank you.
Thank you, Dr. Yang. I think we still have some time for discussion, right? So are there any questions from the panel?
Yes, hello. I'm a consultant in Dubai at the moment. So I also had recently 2 pregnant ladies, one of them was very large, 5-7 centimeter in eloquent area. But since Dr. Young has gone through all the literature, I just want to ask him what would he say are the present controversies and future studies. I mean, AVMs need to be tailored. You need to look at many things. And does he really believe that we can solve all these questions with statistics? And what would be the most burning question in his mind? Thank you.
Right. So I totally agree with you that statistics does not, and as I said over here, that you cannot just quote a 2.2 to 4% hemorrhage risk per year to all the patients. For say, when you have a patient with very large AVMs that are pregnant, that obviously just masks the decision making, whether or not to take it out, the pregnancy, does that increase the hemorrhage risk? So, there are a lot of controversials right now in a lot of regions, in the areas in AVM. For say, that the one that you mentioned, large, hard to treat AVMs, but what if the patient are pregnant? What if they exhibit very high hemorrhage risk and they're very young? What do you do about it? So in reality, the decision making here is very, very hard. What I say is that for large AVMs, you're probably not going to take them out anyway. Basically meaning that if they're a grade specimen grade 4 or 5, you're not going to do surgery and expect them to leave the hospital in a good state anyway. So in those cases, it's really dependent on whether or not the patient has intranatal and prenatal aneurysms, whether or not they're deep drainage, whether or not they have rupture before, and what mean that how high for risk this aneurysm is this AVM is. And if they are very high and high rupture risk, I would suggest try to see whether or not a peripheral treatment, meaning that embolization with radiosurgery, it makes sense for them. And there are other controversials right now. For say, what if you have a pediatric patient with very, very deep thalamic AVMs that had bled before? How would you treat those? Like, are you going to leave those alone? Absolutely not, because they're 10 years old, they have 70 years to live, but there's thalamic AVMs. If you take them out, they will just be hemorrhagic for the rest of their lives. So there's a lot of treatment decision makings that should be, exactly as you said, should be tailored to the patient. Now, statistically speaking, I think what statistics gives us is that a general estimate of how risky your lesion is. For say, if you have a lesion that's superficial, small, non-deep drainage, has been observed for many, many years, that gives you a sense that this is not going to be a high risk, and you can continue to observe it. But then, if you have an AVM that's deep, aneurysms, deep drainage, rupture before, that gives you a general bracket that's saying this AVM is probably going to rupture subsequently, and you should probably do something about it. So I think that's what statistics help us in decision making. Now, the last question you asked is what in my mind is the most pressing. I think there needs to be a way, and exactly as you said, non-statistical way, to give you information based on your prior experience. How would this AVM need to be treated? And I have something in mind. It's not established yet, but apparently. So think about this. So when you're reporting papers, you're actually reporting your own database. You're reporting a summarized component of your database. You're not actually selecting a subcohort of patients from your database to tailor on the patient that you currently treat. You're basically just general reporting on the summary of all your database. Now, that's why we have so many papers divided into deep AVMs, superficial AVMs, pediatric deep AVMs, pediatric superficial, pregnant AVMs, pregnant pediatric AVMs. So will there be a future way of actually real time getting all those data and tailor to one patient? I think there will be, but it does need to take time, and patient privacy apparently is one of the big concerns in these platforms. I hope that answers your question.
So Dr. Yang.
Yes.
So you mentioned the pregnancy. Is it including the time of the to give a birth? Because
it does.
Okay.
Yes.
Okay.
So 40
is it
weeks
different in the different way to give the birth?
Most of our patients in our cohort are vaginal delivery.
Mm-hmm.
Yeah, I have a look at the different. There's not enough data, or there's not enough patients to actually stratify these patients based on different factors, because the largest database I've seen in North America so far is probably either the Virginia or the Columbia database. They have 1,000 patients, 1,500 patients. Of course, Tiantan has like 4,000, but if you select those by female patients, childbearing age, that have complete follow-up, you're basically selecting 1/4 of your database, and this does not give any. This probably you have like around 200 patients, and it does not. You cannot really stratify those patients. The sample size is too small. Yeah,
yes,
and then
yes, I agree. I also looked into this literature as well. Actually, that's true. We just don't know about the cesarean section versus the vaginal delivery, and generally it is being thought vaginal delivery is safe, but then you have to use some common sense as well, I feel. I mean, if the hemorrhage is very fresh, I would rather prefer a C-section under control, possibly combined with a surgical resection of the AVM. Whereas if the things have stabilized, and as you characterize it as they're being cold, then things change. Things really change. And yes, please elaborate.
Yeah, so I've seen questions over here, grade hematoma with AVM stable pregnant patient. As we for the case I've shown here, the reason why we operate on her is because she basically presented with a horrendous HRVH. We generally think that if she were to hemorrhage again, she probably won't survive. So that's why we operate. The general practice over here is to wait for the AVM to cool off, the hematoma to cool off before we do anything about it. That means that means waiting for 4 weeks, 6 weeks, or even longer. The rate of hemorrhage in the first year after first hemorrhage is like 5%. Like, would you actually deal with an angry brain and deal with all those things for a risk of 5%, whereas 95% of the patient doesn't really have hemorrhage in first year? In here, we don't really think that's necessary. So we basically wait for it to cool off, discuss it with the patient. What would you want to do? And radiosurgery, surgery, pick or just observe. Normally we won't observe, and normally those patients, that are deep, we refer them for radiosurgery.
Yes, I completely agree with that, and it really is important. Also, in my case, it was involving the speech area, and perhaps more importantly, all the white matter tracts that connect the speech area, the motor speech area, with the posterior, language areas, and the motor strip. And interestingly, my strategy was I waited, we just put an EVD for a start. It had decompressed into the ventricles, so it had hemiparesis. The lady had hemiparesis. Pregnancy was discontinued, and then to my surprise, she made a gradual recovery. There was no hemiparesis. She started to walk and talk, and that really changed the picture. But that took about 4 weeks, and I had already done an angiogram, and I was prepared and studied everything to actually go in if she bled again and just go for broke. So that would have been my approach again, letting it cool off. And yes, because of her age, I would have risked a major deficit, possibly. I mean, you never know with your surgery, but I would have risked it if she had acutely rebled.
Agreed. Agreed. Yeah, agree. Those are different from aneurysms. The aneurysms need to be secure, but AVMs are dealing with a lifelong risk. It's not that they will just rupture right away. And yeah, Li Ma was asking whether or not there was any difference of morbidity after rupturing AVM during pregnancy or non-exposure period. That's a good question. Short answer is I don't know, because as I said, like you take 1/4 of your entire database on pregnant patients, and then you have like what, 5 to 9 hemorrhages. So you only have data on 9 patients altogether. So can you stratify those patients? For sure, but it will not generate any actually use of, actually meaningful data. So I think there's probably a need to actually gather more patient, multi-institutional effort to address this problem. This is a pressing problem. This is something that we're dealing with like every once a month or something like that.
Okay, Dr. Guo Mian, are you there? Guo Mian.
Yeah.
Yeah, you mentioned I think in the last slides, you mentioned some future plan for this stem cell.
Yeah.
Can you explain it more detailed?
Right.
Yeah.
Yeah, there is another question also to Guo Mian from Dr. Hashard Parak. He asked, how regarding stem cell therapy are you using in patient? What are results? And in GBM, how do make stem cells?
Okay, so there are the protocol online to isolate the glioma stem cells. So it's very common for glioma stem cell research. So we got the glioma sample and cut the sample to species and digest the samples. Use the magic beads with the antibody targeting the stem cell marker on the such as CD133 antibody and the NADOG antibody to isolate the stem cells. So after we select the stem cells, so let's do the gene testing to make sure the cells we isolate is glioblastoma stem cells. So there are the protocol on the line. So we use this method. So for glioma in the past 33 years, so there has been no significant progress in the treatment of glioblastoma. So there are so many methods like immunotherapy, including CAR-T, antiviral therapy, vaccine therapy, tumor treating fields, but the mean survival for glioblastoma is only more than 10 months. So maybe we develop another method to target the glioblastoma. So we work with Dr. Tian from Harbin Institute of Technology. We use this method, inject the biomaterials with the nanoparticles and embed the antibodies to the protein we interested to target the glioma stem cells, maybe a new method. So we hope we can get the ideal result. Oh, that's all.
Okay, great. So Dr. Yang, Professor Yang, you mentioned that a recent paper of UCSF suggested that the hemorrhage during pregnancy typically recovered well. So,
yeah, so
how about your case? You mentioned one case in very serious condition.
Right.
After
so
the hemorrhage.
she started following commands. She started following commands like a few days ago. So I think so. She's 1 week out, one or 2 week out. She came in with complete, GCS3T extension in all extremities. The left side almost the left side doesn't really move, but now she's following commands consistently. And that's given only 1 or 2 weeks. And it's actually, as the previous question was saying, the Dr. Woodley, that this patient's unlike aneurysm patient that they rupture, if you don't have a good blood pressure control, they rupture immediately and they have a poor subarachnoid hemorrhage that gives them a very poor prognosis. The AVM patients, in some part, they behave differently, that they, even if they rupture, you cool them down, they generally recover pretty well. So, I think, again, I think this is not, you're dealing with a bomb, like an aneurysm right now. This is more like you're dealing with a more chronic, lifelong risk that you need to prevent these patients from having a catastrophic hemorrhage in the long run, as opposed to you're dealing with some kind of immediate hemorrhage or immediate poor prognosis.
Yes, if I may add to that, of course, once it has stabilized, you still need to treat it and you need to evaluate it with all the very well-known criteria and discuss it with the patient to go for a treatment and consider surgical treatment. I mean, surgical treatment is the ultimate thing, and it is so much easier once you have very good planning. Having said that, I have dealt with acute AVM bleeds, and they were primarily not recognized as such, which is often a very unpleasant situation because you find yourself evacuating a hematoma and you don't quite know how much you will get. But that also seems to work. And one last remark I would like to make, I was a trainee of Professor Yazagil at the time in Zurich, and he used to say, AVM patients, he's not so worried about them getting into coma. So low GCS means something entirely different from aneurysm bleeds. It really has not the same meaning. And interestingly, if you look at all the criteria published by previous authors and so forth, the GCS scale is not, I mean, you just looked at the literature again, but I don't think the GCS scale plays a major role, is it?
No, exactly. That it's even they present with GCS3T right now, she's like following commands. So it's vastly different from aneurysm rope bleeding. I agree.
So, Dr. Yang, do you have any experience about the medical treatment, like Lipto?
Yeah, I know. So there was, I saw a trial for atorvastatin for AVM conservative management, which has also been the trial for, the drug for chronic subdural hematoma treatment recently. I don't know. I mean, I don't know the mechanism for that. I don't have experience in that.
Okay.
Yeah.
Yeah, I noticed Professor Chen Xiaoling is here. Do we have some comment?
Yeah, I have a question for Dr. Yang. Hey, long time no see. Okay. So as the AVM definition for the AVMs, that is the feeding artery connected to the drainage vein with the needles. That means the directly with the feeding artery and drainage vein. So that means hemodynamic is a very important role, a very important factor for the development and the rupture of any presentation for IVMs. But my question is that, do you have any idea about the hemodynamic research of the hemodynamic clinical applications in your hospital, of any comments for the research?
Now, so that's a very good question. So we don't have research for that currently. I was thinking about that, but as I, right now I'm in the vascular fellowship, and I get a little bit more into like how the angiogram appears. But what I would say is that it's not uncommon for AVMs that presents with a rupture that their initial angiograms are negative, and then 1 week later or 2 weeks later, they reappear. So you might call that. So there are a couple of ways to think about this. So you mentioned that there's arteries, veins, and nidus. Now, is it because of the hematoma compressed on the AVM nidus that closed off the vein, or closed off the nidus so that they initially became like negative, and then 1 week later they reappear? It could be, but then it also could be that their draining vein closes off completely, and then they hemorrhage, and then they recanalize the draining vein, and then they become. So I've definitely seen it's a hemodynamic, very dynamic lesion. It's definitely seen de novos. I've definitely seen recurrence, meaning that the AVM's lesion is completely resected, and then you get a recurrence like in the adjacent area, and then they definitely can go away spontaneously. They definitely can get bigger, and they definitely can present as a negative and recanalize afterwards. So I think it's a very good, promising area to investigate on, like how these lesions behave. But the problem is that in order to get all of those, you will have to regularly follow those patients with angiograms, which is not possible, probably. MRI, CTAs doesn't really tell a thing, in my opinion. Like they tell where the AVMs are, but you really have to see the dynamic, like hemodynamic flow under the angiogram to actually know what the structure is. Yeah, so it's very hard for telling the patient to come back every 6 months to do an angiogram. That's not going to happen. Yeah.
Yeah, because we think the hemodynamic is very important, but nowadays there's not so general hemodynamic parameters in the clinical. So that's why I'm thinking maybe we can get some 4D CTA or 4D angiography or some parameters that could be measure hemodynamic status.
Yeah, agree.
Yeah. So why? Maybe we can find something.
Yeah. And it's a very interesting change, especially when doing angiograms on previously radiated patients. That when they radiate, patients do generally do really well. But then on subsequent angiogram, and we typically do an angiogram in 6 months, in a 3-year time, or actually in a 3-year time, and then later on, if there's still residual, we start following those, and you definitely see prematurely draining veins closing off, and probably that's why some of the radiosurgery patients, they bleed, like during the latency period, that you can't really control where the draining veins, like where the radiation goes, and the draining veins might prematurely close off, and then they started having a hemorrhage. And that's actually one of my experience 2 months ago, that a patient that was previously radiated came back 15 years later, and we compared the angiogram between now and 15 years. And it's very interesting that there are 2 major drainages in the patients 15 years ago. And then after 15 years, one of the deep venous drainage actually closed off. And then the superficial drainage veins start getting larger. So, and he presented with hemorrhage. So there's definitely some correlations with that, I think.
Yes, actually, I also noticed that there's some change in the drainage vein. sometimes there's some spontaneous thrombosis in even in the main drainage, although it's very fast flow, but interestingly, it can be formed some thrombus. And that's the cause of the bleeding.
That's why I think transvenous embolization is still like it's still in my opinion a little bit risky, and just because you don't really know whether or not you can actually go into the into the vein. Like, well, the onyx or whatever the glue they're using, are they refluxing? If they reflux a little bit back into the vein, then you're a host. Like especially in a single drainage vein, AVM, that you partially close off that vein, the nidus will explode.
Yes, I totally agree with that one, because I was just going to ask you, I totally agree with Professor Chen that, the drainage vein and the vein architecture is the single most important factor for the rebleeding risk, in my opinion. The size and location is probably more related to surgical morbidity and so on. But I was going to ask you, the interventionists have actually they present very favorable data with blocking the veins, and really that's what the last thing we would do as surgeons. We would go for the vein as the very last thing to we would leave it open. So yes, any more comments on that, please?
I think that what they're doing is that they, what the transvenous embolizations are doing is that they transvenously access to the nidus. If you have multiple arterial feeders, it's not possible to embolize. Yes, the theory is that maybe treat this as a possible fistula and then go into the nidus and then obliterate the nidus and without hurting the vein. But in reality, when you're passing a catheter through the vein, especially the drainage vein, like you're occlusive to that vein, like your catheter itself, and you're hurting the vein by passing catheters and wires over there. So is it possible? By reviewing some of the papers, they have pretty favorable outcomes for sure. I think if for most part you're lucky that you go into the nidus, you just glue off the entire nidus without hurting the vein and hope for the best that it doesn't explode. But in reality, there's a chance of hurting the vein. There's a chance that the glue reflux into the vein. And if you hurt the vein, you reflux into the vein and close off the vein, cause a hemorrhage, I don't really know how I can defend myself in that case. That's a problem. Like you can achieve 95% good outcome, but that 5% is really hard to defend while you're hurting the draining vein in an AVM.
Yes, actually, I'm both doing the open surgery and also doing the embolization by myself. I never use the transvenous approach because, just as you mentioned, even 1%, if the patient got died, how can you explain it? Yeah.
How can you explain? Yeah.
Mm-hmm. But some radioneurologists, they still treat it, especially in Europe.
Yeah. Mm-hmm. I'm sure, with advancement of endovascular, eventually there will be a solution, maybe transvenous, or combined with other stuff to treat this like endovascularly for very selected patients. But at this point, things are exploratory. I can't really say that it can be applied to a regular practice.
Yeah.
Yeah, I agree with that. I don't like it, but the French school, which has been very pioneering in interventional, they do that. And what can I say? The other thing which you actually, I mean, I'm sure Professor Xu, he knows if he does interventional that the wires actually, these micro wires are extremely soft, so I wouldn't really blame them, but the onyx blocking it the wrong way would probably be the problem, I would think.
Okay, Wan Lee.
Yeah, okay.
I don't have.
Thank you for the
more.
speakers and the audience. The accumulated audience number now achieve around 4,000 for our
Excellent.
first two.
Those
two
are from the
sessions of
days of
this webinar.
Yuha,
Yeah.
from the days of Yoda.
Yeah.
Wow, I'm very honored. I'm very honored. I never
Mhm.
spoke to so many people. Thank you.
Mhm.
Well, Martin, it's good to have you, Martin, to bring
So
some
Martin,
interaction.
you can show your face.
Yeah, we got to get your camera working there, Martin, so
Yeah,
we
yeah,
can
yeah.
meet you. So I'd like to thank, anything else, Ben? Do we have more questions or anything else you want to do?
Okay.
Takashi Kun, right? Do you have
Takashi,
any?
yes. Takashi from Japan.
Wow. Do you?
Yeah, good evening.
something
I'm
like
Takashi
that?
Kon from Tokyo, Japan.
Oh.
Thank you for a very interesting
Welcome.
speech and very informative.
Thank you for coming.
Thanks, Takashi.
Okay, so I think we can close this webinar tonight. And according to our schedule, we plan to do it every 2 weeks, and there will be always the Sunday night. So
Great.
Beijing time, yeah. So
Great.
when we confirm the speakers for our next webinar, we will broadcast.
Excellent.
Okay.
Okay. Thank you very much, Wan Lee. Thank you, Ben. Thank you, Wu Yang and Mian, and also Martin and Harshad for interacting. And we'll see you in 2 weeks.
Okay.